Thank you, Kavita. Good morning, everyone, and welcome to this session on interventions for pulmonary stenosis. I hope I'm audible, Kavita. As you all know, the talk was given as, the topic was rather given as interventions for pulmonary artery stenosis. But I was asked to talk on both pulmonary valve dilatation as well as pulmonary artery dilatation and stenting. So essentially, two of the most commonly performed procedures in the RVOT we will be covering today. So the first one I will talk about pulmonary valve dilatation. I'm sure this is one of the commonest procedures that we all do in the catheterization laboratory. So I'm sure you all would have had very good exposure to this procedure. So essentially, as you know, balloon dilatation is the treatment of choice for valvular pulmonary stenosis. And the indications include a Doppler peak instantaneous gradient by echo of more than 60 millimeters of mercury and or catheter peak to peak gradient more than 40 millimeters of mercury. So these recommendations are from the guidelines published. I've integrated both the guidelines, which are the international as well as the Indian guidelines. Other situations include anatomically significant pulmonary stenosis, but when there is right ventricular dysfunction, which is essentially in the late stage of pulmonary stenosis, irrespective of gradients, pulmonary valve dilatation is considered the treatment of choice. The aim of our clinical management should be to prevent patients to go into this stage, because once the right ventricular dysfunction sets in and right ventricular failure ensues, the morbidity and mortality increases steeply compared to pulmonary stenosis without right ventricular dysfunction or right heart failure, which is a fairly well tolerated disease. And then there is this completely separate or different, I would say, entity, which is the neonatal critical PS, which essentially is defined as hypoxia or duct dependency. So these are generally the indications for dilatation of the balloon dilatation of the pulmonary valve. And there are some other rare indications where a post-operative congenital heart disease, if it is a required tetralogy of Fallot, or variant like VSDPS, where there is recurrent stenosis and it is predominantly at the valvular level, you can still do a balloon dilatation for rehabilitation in those cases as well. So I'll jump into the technique step by step. I hope this is just a revision for all of you, because this is one of the most commonly done procedures in most of the catheterization laboratories across the world. So this is generally done under sedation, and intubation is recommended for neonates as well as those in whom the hemodynamics have already deteriorated, like those who are in RV failure. So an arterial line, at least if you are not planning for a femoral arterial access, at least an arterial line is recommended, especially in neonates and infants. I would say it is better to have it in all ages, because one way of assessing the severity of the pulmonary stenosis is to compare the right ventricular systolic pressure with the systemic blood pressure. So depending on the percentage, like whether it is less than 50%, 50 to 75%, or more than 75% of the systemic pressure, you can classify the severity as mild, moderate, and severe. So, during the procedure, the hemodynamics changes, the systemic blood pressure increases or decreases depending on your anesthesia, pain, a lot of things. So, the ratio of right ventricular pressure to the systemic blood pressure, it remains constant, and that can be looked at to assess your response to dilatation also. That is another reason why an arterial line, I would say, is a must in addition to hemodynamic monitoring during the procedure. So once you have access, then it is a good practice to do a full right heart catheterization. You start with your RA pressure, get the RV pressure, and because there is issue, so there can sometimes be difficulties with crossing the valve. You can do an RV angiogram, which essentially is done in an shallow LAO cranial view and a lateral view. and both of these views are used to measure the annulus. And if there is too much of a difference between both the views, you can look at an average and compare it with your echo annulus and make sure that there is not much of a discrepancy before you go ahead with choosing your balloon. So the right ventricular angiogram is usually done with either an NIH catheter, which has multiple holes, or a Berman angiographic catheter, which essentially is similar to the Swan-Ganz or the balloon wedge catheter, but then it doesn't have an end hole; it only has side holes. And then you can use the angiogram as a roadmap and then cross the pulmonary valve, which is usually done with either a balloon wedge catheter or a right coronary catheter or a multi-purpose catheter or a cobra catheter. So there is a lot of variation from lab to lab, as well as interventionalist to interventionalist as to which is the preferred catheter for crossing, also depending on availability. So the advantage of using balloon inflated catheter to cross the tricuspid valve and reach the right ventricular outflow tract and then trying to cross the pulmonary valve is that you will have a less chance of getting entangled in the tricuspid valve apparatus, which is actually a good thing to do to avoid entangling, because one of the complications of this otherwise simple procedure is that you can damage the papillary muscles of the subvalve apparatus of the tricuspid valve and cause tricuspid regurgitation. So it's a good practice if you can get yourself used to a balloon wedge and use it to cross. And the wires which are generally used for crossing in neonates, most of the operators prefer a coronary wire. A hydrophilic thermo wire is very commonly used. It is easier to cross with this wire, but then you should note that there is a higher chance of RVOT perforation, especially in neonates with the hydrophilic wires. Straight tip Teflon wires can be used. Some of them are the Cook's Roadrunner, or the Cook has a variety of wires which are Teflon and straight tip, which you can use. Or there is another not so commonly used in India, but a very good hardware, which is the woolly wire, which the tip is straight, but it is floppy, so there is a lot less damage to structures by this wire. And then once you have crossed the valve and you have the catheter in the PA, you measure and document the PA pressure. So now you have got your baseline hemodynamics and you have a gradient. So then your aim should be to place the wire on you, which you would dilate the valve as distally as possible. So the more distally you place it in the PA, the more stable will be your balloon dilatation catheter and more easier to position it across the valve. So the wire which is commonly used or should be used is a stiff exchange length wire for balloon dilatation, which should be compatible with your balloon size. So when you're doing pulmonary valve dilatation in a neonate, it is a good idea to pass the wire through the ductus into the descending aorta. That gives much more stability than placing it in either of the PAs. So regarding choice of balloon size, the optimal ratio of balloon to annulus is considered to be 1.2 to 1.25. This is specifically for pliable, thin, dooming valves. If we use lesser ratios, it is going to be less effective. And if we use higher ratios, there is going to be a higher rate of incidence of pulmonary regurgitation, and in the long term that can cause a problem and lead to an unnecessarily second procedure. So once you choose your balloon, you prep the balloon, you use saline plus contrast diluted to 1:3, which is 1 is contrast and 3 to saline, or 1:4. Essentially, this is for fast inflation and deflation cycles. You want the balloon to inflate fast, and even more, the deflation should be faster, so that you do not obstruct the right ventricular outflow tract for longer than required during the procedure. And so the more dilute the contrast, the easier the deflation essentially. So regarding the length of the balloon is another important matter which you have to choose when you choose your hardware for the procedure. So a good thing to remember is the 20-30-40 rule, where you can use 20 millimeter long balloons in neonates, 30 millimeter long ones in infants and smaller children, and 40 millimeter in adolescents and adults. So the problem with using longer balloons is that It may impinge on the tricuspid valve, causing tricuspid insufficiency, or it can press on the conduction system, causing heart block, which can sometimes be transient and extremely rarely permanent. So once you choose the balloon, you prep the balloon, take it across the wire which you have already positioned as distally as possible in the pulmonary artery. You position it across the valve with an angio roadmap. It is good to look at bony landmarks because the crux of the procedure is to get the balloon across the valve and to catch the valve during dilatation so that you don't have to do it repeatedly. So once you're sure that you're across the valve, you dilate till disappearance of waste. Short cycles are preferred, as I already mentioned. You deflate the balloon as quick as possible so that you do not obstruct the right ventricular outflow tract for long and cause hemodynamic compromise. So, if you're happy with your first dilatation, just cross-check it by inflating it once more and seeing that the waste has been eliminated. So once you are done with this, you take the balloon out and then you can repeat pressures and repeat an angiogram. So essentially, when you take the pressures, it is important to take, after documenting the wedge and the PA pressure, what you can do is you should take a pressure in the right ventricular outflow tract just below the pulmonary valve and then in the body of the RV also, because that will help you to realize whether there is an infundibulary gradient or not, because this is one of the complications or one of the issues that we have to deal with when we dilate pulmonary valves. A repeat angiogram will help you to see the improved valve mobility, the increased width of the jet which goes across the valve, and will also help you document whether we have caused tricuspid valve leak with the dilatation or there is damage to any of the structures during the maneuvering for the dilatation. So, I would like to focus once again on some of the pitfalls which I have already gone through. One is the balloon position during inflation. So, the waste can sometimes be from, supravalvular or subvalvular stenosis. So, when in doubt, it is important to move up and down and confirm that you have actually caught the valve. And then, the second is it's imperative to prevent damage to the tricuspid apparatus causing TR. Also damage to RVOT and pulmonary artery. So essentially these can be avoided by, if you can use a balloon inflated catheter or balloon tip catheter to cross the pulmonary valve so that the catheter and later the wire and the balloon doesn't get entangled in the tricuspid valve apparatus. And if you avoid using unnecessarily long balloons, you can prevent damage to the RVOT and pulmonary artery also. The other problem, which I already mentioned, which happens mostly when you use long balloons which compresses on the conduction system, is bundle branch block or complete heart block rarely. And then in neonates, neonates are more prone to all of the complications related to any procedure, of course. The incidence of perforation of the right ventricular outflow tract with the wire which is used to cross the valve is much more commonly reported in the neonates than in older children, adolescents, and adults. So coming to complications, in addition to those related to access and anesthesia, which is common for all procedures, it is seen universally that during dilatation there might be transient bradycardia or premature ventricular complexes and hypotension, because essentially we are blocking the cardiac output by inflating the balloon in the right ventricular outflow tract. Other complications include balloon rupture, CVA, seizures. You can have an air or thrombus or particle embolize from the right to the left and cause issues in the left side of the heart also, left-sided circulation also. So, the VACA registry is one of the oldest quoted or one of the basic registries which give insights into most of the procedures which are commonly done today. So, in that registry itself, it was 0.24% death and 0.35% major complication rate from a large number of procedures from a good number of institutions. So this was in the older days. So today we have more improvised hardware, better images and operator experience. So the complication rate should be even lesser these days. And generally, pulmonary valve dilatation is considered to be a safe procedure in older children, adults, and adolescents. So one of the complications, as I mentioned, is infundibular stenosis post balloon. So this happens in approximately 30% of balloon dilatations. The older the age, the higher the severity of the pulmonary stenosis, the incidence is more. So as I mentioned, if you do a careful pullback after every procedure, you will be able to detect this before it causes serious trouble to you. If the infundibular gradient is more than 50 millimeters of mercury, it is recommended to give beta blocker therapy, and is generally resolved in a period of days to weeks on follow-up. So long term, like when you follow these patients, what are the issues that you might deal with? So one is femoral venous occlusion. Of course, the smaller the kid, the higher the chance of vascular damage. And recurrent stenosis has been reported in 8% in large series after long-term follow-up. So when somebody has a recurrent stenosis, again, you have to identify the cause. Look at the echo carefully, do a catheterization study, and see where the gradient is. Look at angiograms. If it is valvar, again, the treatment is redilatation. If you find subvalvar or supravalvar stenosis to be the cause for recurrent stenosis, then surgery is the treatment of choice. On follow-up, pulmonary regurgitation has been noted in a good number of patients. The incidence has been reported to be as high as 88% in one of the large series with very long follow-up. And the good thing was that only less than 10%, the thing is, pre-procedure PI, very sorry, was there only in 10%, and the post-procedure, the incidence is high. But then the good thing is that they rarely require intervention for the regurgitation, and the incidence of requiring something to be done for the pulmonary regurgitation after balloon dilatation for pulmonary stenosis is less than 10%. The number quoted was 6% in one of the old series. A quick word about the double balloon technique. So this is not commonly used these days. This is preferred by some operators for larger annular sizes, especially in adults. How do you do it? If you need to take two accesses, you have to have two wires on either PAs, and then two balloons are simultaneously positioned across the valve and inflated simultaneously. So there are formulas to calculate the effective balloon size. Like, you do the angiogram, you measure the annulus, and you decide the size of the balloon that you will need to dilate as if you were using a single balloon. And then if you are using double balloon, you calculate using certain formulas or charts and find out what combination of balloon diameters will give you that effective balloon diameter. That is how you choose the balloon if ever you happen to dilate a pulmonary valve using a double balloon technique. So there was one head-to-head comparison study. The results were excellent by the double balloon technique, but it was not better than a single balloon technique. And then these days you have balloon catheters with large sizes. You essentially do not need two balloons to dilate the pulmonary valve because of the availability of these big catheters. So the problems with the double balloon technique, as you know, is it prolongs the procedure time because you need two accesses, two wires, two balloons. And essentially, because of all these reasons, double balloon technique is not that favored these days. We will have a quick look, at this entity, which is very different from the valvar pulmonary stenosis that you see in older children or adolescents and adults. So in the neonate, when the patient presents with severe pulmonary stenosis or critical pulmonary stenosis, by definition, it is drug dependent. There is either hypoxia or diffuse cardiac output, which is supported by a right to left shunt to the PFO. Essentially, all these babies are on prostaglandin infusion. And one thing that I would recommend before you decide on dilating these patients is to look for right ventricular hypoplasia on the echocardiogram as well as the angiogram. This helps you as well as your team and the family to be prepared with the post-procedure course of events. Suprasystemic artery pressures are very common in critical PS. And the other important thing is that gradients might not be reliable. So proper planning is very important in critical PS dilatation, mostly because as I mentioned, gradients are not reliable, and then you have to depend mainly on accurate balloon sizing and making sure the balloon got the valve. So that is where you can make sure that you've done a good job. If you are lucky to get a good gradient across the valve, high right ventricular pressures to start with, and then after dilatation it came down, then you have something objectively to make sure that your dilatation has done something, or you have relieved the stenosis. But then very often the right ventricular pressures and the PA pressures are still high, so you do not get a good gradient to start with. You do not get a good reduction after your balloon dilatation, and then sometimes what you can see is all a suprasystemic pressure come down to systemic. So essentially, your planning should be meticulous. You should know what is the largest size balloon that you can use in this case. Make sure that you use the right size balloon and you catch the valve, and then whether your dilatation was effective or not, the baby will tell you in the coming days, showing resolution from hypoxia, ability to wean off prostaglandin. Um, so, higher mortality and morbidity has been reported in literature in neonatal critical PS dilatation compared to older children. So, some of these babies may require prostaglandin support for longer, even if the right ventricular size is normal, because a non-compliant, a hypertrophied non-compliant right ventricle, or you call it diastolic dysfunction. So because of that, there can be right to left shunt through the PFO, and these patients might need support for longer. The institutional practice varies as to how long you will support with prostaglandin before you decide on an additional procedure to provide an extra source of pulmonary blood flow to maintain the oxygen saturation. The procedure, which is usually adapted in most centers, is either a ductal stenting or a BD shunt. So essentially, if your RV is of good size and your valve was pliable and you did a good job in the lab, you should be able to get the baby of prostaglandin in either the same day within a few hours itself. But then a good number of them will require support for a couple of days. Some of them might need even for longer. So it is essentially a team decision as to how long you would like to support the baby with prostaglandin and see, as PA pressures come down, as the RV pressures come down, the right ventricle remodels, and the complaints increases, of the diastolic dysfunction part gets better, and the right to left shunt across the PFO decreases, and the baby requires less prostaglandin. So the duration essentially is a matter of institutional choice. Also, re-intervention rates are reported to be higher in critical PS. And I've given the numbers from a long-term outcome study from SickKids Toronto. So in the same study, they have also documented, which is an important thing, is that they have documented improvement in pulmonary valve leaflet mobility, pulmonary valve annular Z-score, and even reduction in prevalence of right ventricular hypoplasia. So if you can open the valve properly, and support the baby during the immediate post-procedure neonatal period, as the baby grows, there is a good chance that that is the only procedure that the baby ever required. So I will show you an angiogram here. So because we cannot interact during the session, I will just describe. So this is a right ventricular angiogram. In the lateral view, you can see a Berman angiographic catheter coming through the tricuspid valve and into the RV apex. And if you look closely at the valve leaflets are essentially thickened. They are not pliable. They are not. This is not a typical Dunning valve. This is a typical example of a dysplastic valve. So when you do the angiogram, you can also note that the tricuspid valve is competent. There is not much tricuspid regurgitation. You can also see in the levo phase the whole aorta as well as the LA. So this is exactly how a dysplastic pulmonary valve looks. So that is why I wanted to show this angiogram. So now we will discuss a little bit about this entity. So thickened, nodular, redundant valve leaflets with minimal or no commissural fusion and hypoplastic annulus. So there is no, it is not thin, it is essentially thick, and you will not see the typical dooming movement. So even though the valve is dysplastic, even in dysplastic valves, the first line of management is still balloon dilatation, and the recommended balloon to annulus ratios for dilatation in dysplastic pulmonary valves is more than those in the typical or dooming thin valvular pulmonary stenosis. So the ratios recommended are up to 1.4 to 1.5. So this is a dilatation of the same dysplastic pulmonary valve with the Cordis PowerFlex balloon, which is a very non-compliant balloon. You can see that the balloon is at full inflation above or at the rated burst pressure, and you can see that the waist is still there. The waist is unyielding. So this is how the dysplastic valves cause trouble. They do not yield to even relatively high pressure dilatations with higher balloon to annulus ratios. So when you do not get a good result with the balloon, of course, if the gradient subject is to at least moderate levels, you can still continue and wait for some time. But then if it is on the severe level, more than 2/3 or 75% systemic pressures, then you have no other option than to send for a surgical pulmonary valvotomy. So that was the first session on balloon dilatation of the pulmonary valve. Now we will come to the second commonly performed procedure, which is pulmonary artery intervention. So jumping to indications. So these are the classical indications for dilatation or stenting of a pulmonary artery. These I have adapted from the international recommendations, ACC/AHA recommendations for interventions. So gradients of more than 20 to 30 millimeters of mercury across the stenotic area, elevation of right ventricular or proximal PA pressure to more than half to 2/3 of systemic pressure. So a good way to look at it is like, if the RV pressure to systemic pressure ratio is more than 2/3 to 3/4, even if there is no other additional, there is no symptom, there is no hypoxia, or there is no desaturation from right to left shunt, still you have ground to go ahead with dilatation. But if it is just at or more than half, then it is better to have and some other reason to go ahead, like two indications to go ahead. So if you do a flow study, ratios of more than 35-65% or worse, I would say, is an indication to go ahead and do the procedure. And some things which you have to note, which I'm sure most of you would be aware of, is like, even smaller gradients are significant in low flow settings like the Glen and Fontaine. And sometimes even in the two ventricle circulation, the gradients are not reliable because of the decompression runoff to the opposite lung or other segments of the same lung. So, anatomic severity is also important. So the techniques, essentially, you can do either balloon dilatation or stenting. Balloon dilatation can be done with simple balloons or high pressure balloons. Sometimes for non-yielding lesions, you can score with a cutting balloon. So the cutting balloon has small blades on the surface. So we have to be very careful and very experienced if you are using a cutting balloon. So where you use it is, lesions which have been subjected to repeat dilatations and not yielding with high pressure balloons. And what you do is you score with the cutting balloon. Essentially, the cutting balloon creates cracks on the intima, and then you dilate with your usual balloon. So then that gives a better chance of giving a better result, of course, with a slightly increased rate of complications. And the other option is to stent the pulmonary artery. So when do you dilate and when do you stent? We will come to it as we go through the talk. So essentially, balloon dilatation is successful in up to 3/5 of stenosis. How we choose a balloon size is a combination of factors. One of which is look at the narrow segment and maximum 2 to 3 times the size of the narrow segment. The size of the balloon that you choose should not be more than the size of the adjacent normal vessel. And another important thing to remember is the weight should be at least 50% of the balloon size. If it is too small a waste, it can be a reason for a rupture. So that is another thing to look at. And you should thin compliant balloons are not a good choice for a pulmonary artery dilatation. The burst pressure should a minimum be 6 atmospheres. And again, always shock cycles are preferred, but if you are more distally in the pulmonary artery, you have a runoff to the other side, especially when there is no stenosis on the other side. Then you have a little bit more of space to dilate for longer. But essentially, it is good to dilate for as short as possible. So how do you do the procedure? You give your anesthesia. You give your essentially, I would say you should not do a PA dilatation without an arterial line, because you have to, because these can be long procedures. The hemodynamics at the start will be entirely different from the hemodynamics at the end. So you should have a baseline or something to compare. As I mentioned, the ratio. So always have an outline. Do the right heart study, a full right heart study. Do angiograms to profile the lesion. You can use, the angle at which you can best see depends on where the lesion is, whether it is right or left pulmonary artery, whether it is proximal or distal. And it is a very good idea to do a non-invasive imaging before you go ahead to the cath lab, because you can have an excellent idea about measurements, where exactly is the lesion, what view you can use. So either an MRI or a CT, depending on the situation. Sometimes if there is associated pulmonary valve issues, pulmonary regurgitation, then an MRI is a better choice. If it is an isolated pulmonary artery issue, then you will be fine with a CT. So do your measurements on the CT and do all the homework on the CT. Make a complete plan for the procedure. What size balloon you will require based on the CT, what size sheet you will require. So have a good plan, because sometimes you end up being in the lab for long when you start dilating pulmonary arteries. So once you do the angiograms, you do the size measurements, you cross with an end-hole catheter and a hydrophilic wire, and then you always dilate on a stiff wire for support, and you choose the balloon the way I mentioned before, looking at a number of things, and then you dilate the balloon. Dilate with the balloon, and then you repeat hemodynamics and an angiogram. Both are must, because these are the ones, these are what will tell you whether your dilatation was effective or not, and whether you have caused any complication or not, more importantly. So what do you expect? So if you get approximately 50% improvement in diameter and 50% decrease in gradient, this is an acceptable result. And on flow studies, it has been found that essentially most of the effective balloon dilatation cause at least 50% improvement in flows. So as I already mentioned, non-compliant balloons with higher rated burst pressures increase success, and non-yielding lesions can be dilated with a cutting balloon and then dilated with simple balloons. So PA balloon dilatation is one of the interventions with a high rate of complications. It can cause intimal flaps, a rupture. So the rupture rate is less than 1 to 2%. Aneurysm formation at the site of dilatation, and then reperfusion edema, sort of pulmonary edema after to dilate. Then of course arrhythmia, hypotension, access site complications, anesthesia related complications. The restenosis rate with just balloon dilatations is also pretty high, around 10 to 44% reported in various series. And so as I mentioned in the beginning, so when do you decide to dilate a PA and when do you decide to stent a PA? So essentially, because of higher intervention rates and higher complication rates, stenting is a preferred procedure, but then not all patients can be stented. So this balloon dilatation is essentially the strategy for smaller patients in whom stents cannot be implanted. So when do you implant the stent? So you implant a stent in the PA only when you know that the baby's blood vessels, heart can accommodate or is ready to take a stent which can be dilated to adult size. So that is the dictum. That is how you decide whether this patient should get just a dilatation or a stenting. And this is in elective procedures, but then sometimes we have a baby immediately post-op who's on ventilator, not coming out of the ventilator because that there is a PS stenosis which is causing high RV pressures, or somebody is on ECMO for the same reason. You have to get the baby out of ECMO or ventilator, and then in those situations, the post-operative situation is one place where you prefer a stenting to a dilatation, even though you know that you might not be putting in an appropriate size stent because it is just to get the baby out of a dangerous situation. So this is one of the well known acclaimed studies on there are hardly when you compare the pediatric intervention data with adult intervention data, what you will see is there is much less of trials of studies in the pediatric arena, but then this is one of the well coordinated, well collected data from registry, a US registry. Um, uh, so, uh, so 20. This was a study which was coordinated by Boston, and a good number of centers from US contributed their data to this registry, and they analyzed complications of PA interventions, including both dilatation and stenting. I will come to details of stenting later, but this complication rates are including both dilatation and stenting. So in this registry, where they had 1,315 procedures, 22% had some or other complications, which included vascular or cardiac trauma, technical adverse events, arrhythmias, hemodynamic adverse events, bleeding via endotracheal tube. So that is either because of a damage to the distal pulmonary vessel by your wire, or because of a rupture of the pulmonary artery by dilatation. So 10% of these adverse events were of high level severity, and 22% in this registry had re-intervention. So they identified some factors for increased incidence of adverse effects, which included hemodynamic vulnerability, young age, use of cutting balloons, and of course lower operator experience. So these were the risk factors for adverse events on multivariate analysis. So I will show you a complication from a PA balloon dilatation. So you can see that this is a post-operative patient. You can see the sternal wires. You can see a pigtail catheter in the aorta for our systemic blood pressure monitoring. So you have a catheter coming in from the tricuspid valve, RV going all through the RVUT into the left pulmonary artery. So there is a coronary wire distally there. So this is a small baby because we're using a coronary wire and a hand injection. So, sorry. Okay. So you can see that this is one of the, this is a patient who has been palliated multiple times. You can see stents in the right pulmonary artery, stent in the left pulmonary artery. Still, you have multiple stenosis. So this should be a syndromic patient. The syndromic patients have higher incidence of multiple peripheral stenosis, and it's very difficult to palliate. So this kid was taken in for systemic RV pressures, right left ending to the PFO, and early right ventricular dysfunction. So here you can see, a tubular or diffuse narrowing of the left pulmonary artery distally here, and this was a target for dilatation during this, and so the lesion was dilated. See, now we can see that the area has become bigger, but then it is sort of going in for an aneurysm. So, and this is essentially what happens when you have to dilate using high pressure balloons or cutting balloons. So this was done with a high pressure balloon. So in most of these syndromic patients, you end up dilating with high pressure balloons, and then you can see a small aneurysm. So what do you do now? So essentially, we waited for quite some time to see how the aneurysm behaves. And after some time on repeat injection, this is what we saw. The aneurysm has become bigger, and the intimal flap, which was created by the balloon proximally, has shut down. So essentially, the aneurysm is getting bigger, and you cannot leave it like that. If you leave it like that, it can rupture, cause bleeding into the lung, and then you will lose the baby. Especially in these babies where they have systemic and suprasystemic RV pressures, they are prone to adverse events much more than those with lesser right ventricular pressure. So what we had to do, we were forced to put a covered stent there to exclude the aneurysm. So this is the covered stent. You can see it, and now you can see that the covered stent has taken care of the stenosis as well as excluded the aneurysm. So when you put a covered stent or any stent of a small size into a small baby, you are committed to, either dilating it to bigger sizes on follow-up. I will go through it when I mention the stenting part. So you are committed to dilating it serially on follow-up, or taking it out or cutting it out and taking it out during your second surgery. So that is what you are committed to when you are forced to put a small size stent in the pulmonary arteries. Coming to stenting, as I mentioned, gives improved acute, intermediate, and long-term results indicated in patients or vessels large enough to accommodate stents dilatable to adult sizes. So other indications, restenosis following balloon angioplasty, intimal flap following balloon dilatation, compliant stenosis, that is the variety where the vessel recoil hinders optimal results. So it dilates, but then as you remove the balloon, it recoils back. And then another entity is stenosis due to kinking or tension. Like, if you see patients on follow-up after arterial switch, the Lee Comte, you can see that, the pulmonary arteries are essentially stretched, and the stretching and compression on the aorta can cause stenosis. And if it is significant, then if you just dilate, it is not going to give any results. You will end up stenting. And of course, stenosis from extrinsic compression. This is common in the post-Norwood or situations where you have a huge aorta compressing on the PA. In such situations, also dilatation will not help. You have to essentially keep the vessel open by stenting it. The technique is essentially similar to balloon dilatation. Pre-dilatation is not recommended unless we expect difficulty to pass the long sheath, which you will use for taking the stent in across the lesion. So what are the stents that can be dilated to adult sizes? So it is essentially the older generation Pharma stents or the Genesis XT stents. So these are all unmounted stents and need to be hand crimped onto the balloon of chosen size. So how do you choose the balloon? Again, the same. So it should be, not more than the diameter of the adjacent normal vessel. And then the length should be normal to normal. So stenting is always done through a large sheath. You choose the sheath size, which is 2 Frenches more than what is required by the balloon, and then you place the sheath across the lesion, and get your stent mounted, take the assembly in, and then you withdraw the sheath and then expose the stent across the area where you have to stent, and then dilate, and then you repeat the hemodynamics and angiograms. So complications specifically to stenting, stent malposition, again balloon rupture. Also you can jail vessels, like if you have branches coming out of the area where you have stented, you can jail the vessel, and then you might have to recross and dilate through the stent struts. And stent fracture is also a rare complication, but then it is much less than if you compare with the fracture rates in RVOT stents. So issues of the PA stenting. So need of redilatation, as I mentioned. So to adapt to the stent diameter to the patient growth, or sometimes to deal with neointimal hyperplasia, or sometimes to deal with external compression, you might have to redilate the stent. And as I mentioned, syndromic patients, TOF, AP collaterals, these patients are prone to have restenosis. And sometimes we have stenosis across bifurcation, so you can you can just stent the main vessel and then look at the other vessel, see if the other vessel is compromised, as I said, if it is jailed or not, if required. Even you can recross through the struts of the first stent and dilate. I will show what I am saying. So essentially here, you have stented the RVOT, and the second stent is into the left pulmonary artery. So this is like a bifurcation stenosis. So here what you do is you stent across to the mainly narrowed artery, and then if you do an angiogram, you might see that this has jailed the right pulmonary artery. Then what you do is you cross to the stent struts and get a balloon across the struts and dilate the right pulmonary artery. So sometimes this is enough. So otherwise, you can, if both PAs are involved proximally, you can use two stents, but then you have to deploy simultaneously to avoid crushing. Like if you dilate only one stent at one time, you can crush and narrow the other stent. So you have to dilate both stents simultaneously. So this is actually a complex lesion where that the MPA as well as the both the branch PAs are involved. So you can either put two stents which extends into the MPA there, or you can use three stents where you put one in the MPA and two into either PA. So these are all options when you deal with bifurcation stenosis. This is more important once we start doing percutaneous pulmonary valves, where you have to tackle the distal vessel also percutaneously. So I will go through a case. This is one of the typical examples of a patient with who required multiple interventions. So at the time of the last intervention, this baby was 3 years, weighing 15.5 kg, top pulmonary atresia, underwent repair with a patch from RVOT extending into the LPA. And 3 months post-surgery, the patient required balloon dilatation of both LPA and RPA for systemic right ventricular pressure. And then again, the baby required a redilatation using cutting balloon when the right ventricular systolic pressure again increased. So both these procedures gave significant angiographic improvement and reduction in RV pressure. And then again on follow-up, this is what was seen after 1 year after the second dilatation. So you can see that both the PA osteums are narrowed. So this is essentially sort of a bifurcation stenosis involving, this is a CT, as you all know. Sorry about that. So this is a bifurcation stenosis involving both the right as well as the left pulmonary artery. The left pulmonary artery, if you see, is like a diffusely smaller one. The right distally is sort of better size. So the right, so how they did a CT was that they saw rising right ventricular systemic pressures, and so the gradients go up against on both PAs, and then did a CT, and this was what was found, and it was decided to tackle with this again in the cath lab. So this is an angiogram in the caudal view. So there is overlapping of the PAs, and so we can't see the proximal vessels, and that is exactly why I always mention that you should use a non-invasive method of imaging so that you can plan your procedure well before you go into the lab. You do not have to look at angiograms and then start thinking. You have a plan. You know that the stenosis is significant. It is just that because it is overlapping, you can't identify the severity as well on the angiograms as in the CT, but then the RV pressures were 67 to 70% systemic in this patient. So then it was decided to go ahead. So it was a planned bifurcation stenting. So after the angiogram, you place the two sheets across both PAs, cross both PAs, two axes cross both PAs, two sheets across both PAs, and you can see that we have already positioned stents across both PAs also. So this is, you have to do simultaneously as I showed in the pictures, otherwise you will crush the one of the stents. And then you dilate simultaneously. So this is simultaneous dilatation. And this is balloon dilatation after stent. If the stent first was implanted and then we dilated once more, simultaneous kissing balloons. So any bifurcation at the end needs to be dilated together, which you call as simultaneous kissing balloon dilatation for optimal expansion of the stents. So that was one of the difficult cases. So take home messages. So balloon pulmonary valve dilatation is a common procedure, safe. If you give attention to details, you can avoid pitfalls and do the procedure safely. Critical pulmonary stenosis in the neonate is, of course, a higher risk procedure and is technically more demanding, but it is, of course, a life-saving procedure too. And pulmonary artery interventions are high-risk procedures, requires hard work, and both you and the patient are committed to regular follow-up and repeat procedures or surgery as needed for rehabilitation. Thank you all for your patient attention. If any of you have questions, I'm happy to answer.